carry on. Okay. So my goals for today are to inform clinicians and infection preventionists in Northeast Arkansas of the growing tuberculosis cluster in this area. I want to use these cases to educate physicians on the signs, symptoms, and radiographic findings of tuberculosis, and they're quite an illustrative group. And we're doing this because we rely on you to find the cases and to help us to break the chains of transmission. And I also want to share how the Department of Health can partner with clinicians to get patients evaluated expeditiously. So the cluster overview. This cluster started in St. Francis County and has only later spread to Craighead. At this point, hot off the presses, we're up to 27 cases documented since 2021. We identified 4 in 2021, 4 in 2022. One of those was in Texas, but shuttles back and forth to Arkansas. And in 2023, the dam has broken open, and there have been 19 more cases identified. 3 in Arizona, another one in Texas is the latest addition, and there are now 6 cases in Craighead County. The cluster is about half and half adults and children. The adults are remarkable for being young adults in their 20s and 30s, many in their early 20s. 10 of them have AFB smear positive sputum. 8 of them have cavitary disease. So these are people who have had long infectious periods before they were recognized. And of the 13 children, they range in age from 2 to 18. Over half, 15 cases, have been hospitalized. So over half the cluster, and several of those have been children. There was one 20-year-old young man whose life hung by a thread for several weeks. Another child was hospitalized for several weeks, very ill. So it's a nasty germ, and we would love to see its romp in Arkansas come to an end. And these are not just pulmonary cases. There are 3 of these cases have had disseminated disease, including one child. One is a straight up TB meningitis, and another has POTS disease. So again, a nasty germ. All of these cases are US born, all African American that we know of so far. They all have connections to Forest City, Arkansas, that we know of so far. Some sites that are of note are employers that some of the patients have reported: Boar's Head, Hino Motors, FMC Conveyors, and some others. I do want to take the opportunity to give a shout out to Boar's Head, who did a spectacular job of working with us and doing contact testing at their plant and found no associated cases to the one that reported working there. But they were awesome and an absolute model of cooperation and concern for public health, for the sake of their employees. So kudos to them. Also, the Arkansas Department of Corrections and St. Francis County Jail are sites that have come up again and again as we've talked to patients. 54% of the adult cases report a history of incarceration, and 92% of the adult cases report marijuana usage. Now, I'm noting that because this is actually the second really big cluster of TB cases that we've wrestled with here in Arkansas over the last several years. The other one was in Southeast Arkansas. Very similar. The folks that we knew of were US born, and again, a very close-knit group. And we actually had to have a CDC EpiAid team come and help us sort that cluster out. And so we took a deep dive into cases and histories. And what we learned was going on in that cluster is that a bunch of these folks would get together and smoke pot together. And it turns out that if you have TB and you smoke a joint and pass it to the next person, that's a pretty good way of sharing TB with them as well. So we don't know that that's what's going on with these cases, but it could be. Okay, so how do we know that these cases are even related? The short answer is genetics. So all positive TB isolates get something called genotype analysis done to identify the genotype. If multiple isolates of a particular genotype are identified, then something called whole genome single nucleotide polymorphism, or WG-SNP analysis, is done. SNP for short. It's easier and cuter. So that will further assess the genetic relatedness of the isolates. And this technique, the whole genome thing, will actually cover over 90% of the genome. So a SNP is a change at a single nucleotide position. So dig back to genetics when we looked at the A, T, C, and G in the DNA helix. So a SNP is a change at a single nucleotide. Isolates that are closely related have less than 5 SNPs difference between them and indicate likely recent transmission. And then we take this information and we map it onto something called a phylogenetic tree. So here is the tree for this cluster, and this was updated just a couple of days ago, so this is very recent. Let me tell you what you're looking at here. This node here that looks like a pie with a bunch of slices are all people. Each slice is a person who has exactly the same whole genome sequencing results as everybody else in this slice. There is no daylight between these isolates. The deep kind of teal colored slices here and out in the other nodes, those are Arkansas cases. The lime green are Texas cases, and the purple is an Arizona case. So these guys are exactly identical. These people, these circles out here also represent people. They are one SNP apart from this group. They're not one SNP apart, but not the same SNP. So this person has a distinct strain, that one another, but only one SNP apart. So these are extremely close, and so that we know that this whole thing is a big cluster. The white wedge is not a person. It's a thing that would take too long to explain. Most recent common ancestor. Oh goodness, there was another. Oh yes, so I did want to say one other thing. So if you're like studiously counting up the number of people we have here, the number is not 27. And the reason for that is because we can only do this on people for whom we have positive cultures. So and remember, I told you the cluster is almost half kids. It's hard to get positive cultures out of children. You know, they can't cough up sputum the way adults do. And so often children are what we call clinical cases. The clinical case in TB, it looks like a duck and it quacks. It has all the features of TB, but you just don't have a positive culture to confirm it. But those children are strongly epi-linked to this cluster, and we have no doubt that that's what's going on with them. So to take a look at the Craighead County cases then. Okay, case 1 is a 35-year-old African-American woman who had actually been treated for what was thought to be latent TB with INH and rifapentine back in the fall of 2022 after she was tested for TB by her rheumatologist. We don't know why she was tested. She did not report symptoms at the time. Could be that they were considering putting her on a biological agent. However, she did have a chest x-ray done. It was read as normal by both the chest clinician and the radiologist, but through the retrospective scope, we don't actually think it was normal. She probably had active TB at the time it was done. In fact, I'm certain that she did. And we'll look at that x-ray in just a moment. But she presented to the St. Bernard's emergency room in July of 2023 with a quote unquote several day history of productive cough, shortness of breath, fever, chest pain, abdominal pain, nausea, and vomiting. I'm going to guess that several days is not accurate. This woman, I think, had been sick for a significantly longer period of time. Her diagnosis was yielded by bronchoscopy, and she had 4+ AFB positive smears. So looking at her image here, you can see in the left upper lobe, we have a large opacity, a large infiltrate. Within that opacity, we have an area of lucency. Not well demarcated, but it's there. And I want to tell our clinicians that if you see an area of lucency within an area of opacity on a chest x-ray, that should put a little red flag in your mind that this could be an area of cavitation. Sure enough, here's her chest CT, and you can see that she did in fact have a very thick walled cavity in the left upper lobe. Here's some of that parenchymal infiltrate that we saw on the chest x-ray. Has kind of a largely a sort of a nodular pattern. She has an early cavity happening here as well. So going back to her film of July 2022, again, she didn't report symptoms at the time. Her T-spot was strongly positive though. And interestingly, she reported having had quote unquote pneumonia in April of 2022, three months prior to this chest x-ray. But let me, and she had a chest CT that was abnormal at that time as well. So let me tell you what I'm seeing here. And it's subtle. Like I said, even the radiologist missed it. But what I see here is under the left clavicle, she has an area of opacity that is very subtle. But if you look over here, that's an asymmetrical finding. Again, I get to look at it through the retrospectoscope, but now that we're staring at it, I hope you guys can see it as well. Zooming in closer, here is a close-up of her x-ray, and I really hope you can now see it here. It actually extends beyond the collarbone. Again, an asymmetric finding. This is the inverted view where you see the same thing. Looking at the chest CT we discussed, here is the current one that we looked at. This is from April of 2022, and you can see in this exact same location, she has kind of a fibronodular opacity. She also had a chest CT done in November of 2022 that showed the same thing, but with a little progression. But TB was not suspected during any of those previous times. So her infectious period very likely dates back to early 2022. All right, case 2, 35-year-old African-American man presented to St. Bernard's emergency department also in July of 2023 and was admitted. He gave a 4-month history of cough, chest pain, shortness of breath, weight loss of 30 to 40 pounds. And this was his chest x-ray. You can see he's got a large infiltrate in the right upper lobe. Again, an area of lucency within the opacity, but here we've got a pretty well demarcated wall. You can see it's circular. I mean, this should smack you between the eyes as a cavitary lesion. His sputa were 4+ smear positive, and his cultures were still positive 3 to 4 weeks into treatment. He was in Jonesboro, but had close family ties to the cases in St. Francis County. He worked at Kentucky Fried Chicken at the time this was taken, so he had had a long infectious period. Unfortunately for his coworkers, he also reported a history of housing instability. Here is his chest CT, shows an enormous cavity in the the right upper lobe that has these internal bumps that are pretty typical for TB. And you can see some parenchymal disease out here in the left upper lobe as well. This is a cut that's a little bit lower, but shows some wonderfully illustrative things about TB. He's got an area of consolidation out here with an air bronchogram. You can see that in various kinds of pneumonia, but here's what's particularly interesting. He has what we call a tree in bud pattern. And if you look at this, you can see the airway and these little kind of nodules coming off of it that look for all the world like a tree in bud. What these are alveoli and terminal airways that are stuffed with purulence. And the tree in bud pattern is not pathognomonic for tuberculosis, but if you see this on a chest CT, it should be the first 3 things in your differential diagnosis. Case 3 is a 21-year-old young man who was sent to the St. Bernard's emergency department by his employer due to nausea and vomiting at work. In the ED, he also gave a history of productive cough and weight loss for a month. They did an abdominal CT because of his complaints, and it showed cavitary pneumonia. We'll look at it in a moment, but the abnormal chest lung tissue that was seen there prompted this chest x-ray. And here you can see he has multiple cavitary lesions. And if you look at the lung parenchyma down here in the right lower lobe, you can see it has a very fine, sort of fluffy nodular pattern. This is not a miliary pattern, but is actually an alveolar pattern, and we'll look at it on the CT in a moment. And it's subtle, but if you look over here in the left lower lobe, you can see the difference between those. This is normal lung tissue, and this is not. His sputa also was 4+ smear positive, MTB PCR positive, and he reported working at FMC conveyors. Here is the abdominal CT. This cut is lower than, it's in the lower part of the lung. So we see that the cavity that we saw in the peripheral lung field. Down here, like the other patient, he also has a tree and bud pattern. And you kind of can particularly pick it up in this area. Again, the top 3 guesses should be TB. Case 4, getting out of my wheelhouse here a little bit, because these are now into the pediatric cases who are managed by Dr. Dahl, who may or may not be at the call. I can't tell. But if he is, then hopefully at the end of the presentation, he'll be able to chime in if you have questions about some of these. So this is a 5-year-old nonverbal autistic African-American boy. He was taken to the Lebaner Hospital emergency department in Memphis with a 3-week history of fever, abdominal pain, decreased oral intake, weight loss, and night sweats. He had a positive T-spot, and they did some gastric aspirates on him. So those serve as our proxy in pediatric patients. Because you can't get a little guy to cough up sputum for you. They'll kind of cough stuff up and then they'll swallow it down. So we go and try to aspirate it out of the stomach to recover it. He had a history of exposure, a household history of exposure to case 2, the cavitary case we discussed above, and others in this large friend and family group. And his chest film shows this opacity in the right lower lung field. It has a rounded appearance to it. This may be partly hilar adenopathy. It may be partly lung parenchymal. It's kind of hard for me to tell them apart here. He also has right paratracheal adenopathy. And in pediatric cases, sometimes you'll see TB disease appear as adenopathy rather than pulmonary infiltrates. Case 5 is his 8-year-old brother, who was also admitted to Lebaner, not because he was particularly sick, but because they knew he'd had this exposure to TB. And often with these little guys, if they test positive and have a positive chest x-ray, which we'll discuss in a minute, they get admitted to have the gastric aspirates done overnight, and then they get released. So his only symptom was an unspecified amount of weight loss. And here is his chest x-ray, where you can see actually a large infiltrate in the right mid-lung field. He may have a little paratracheal adenopathy going on here. I can't even comment on the right hilum. I can't see it. It's obscured by this, this infiltrate, which actually extends all the way down here. So it's actually kind of surprising that he was not more symptomatic. Case 6, a 14-year-old girl. She was tested as a contact to her mother, who happened to be case 1 that we discussed above. So her test came up positive, and here is her chest x-ray, which shows kind of a sail-shaped infiltrate in the right mid-lung field. On the lateral view, this projects to the superior segment of the right lower lobe. In spite of this, she was asymptomatic, but clearly has active TB. All right, case 7 is not a Craighead County case. We're back to St. Francis County here. This is one of our most recent cases, and I'm sharing his case with you because it's interesting and illustrative and frankly kind of horrific. Unfortunately, he's a good teaching case. So this is a 2-year-old boy who is epi-linked to multiple family members with active tuberculosis. And he only recently got his diagnosis of TB, but he's been symptomatic back to July with fever, back pain. He had developed a limp and started tripping and falling. And his family reported that they actually saw a new visible bend in his spine. So here are his images. So this is the vertebra, or what's left of it. You see good calcification up to here. After this, it disappears, and we see paraspinous abscess here. This is actually his heart here. On this view, this vertebra is conspicuous by its absence. It has been crushed. And here we see paraspinous abscess on both sides. In the lateral view, this is the vertebra that is no more. It has been completely crushed, and some of its calcified parts have been forced forward. This is a prevertebral abscess. And you can see the bend that his family's talking about here. His diagnosis actually came from an aspirate of this abscess. So it turns out that he has Pott's disease at the T7 to 8 level with severe spinal canal stenosis and paraspinous abscess. So this is a terrible case. All right, so our take-home points. The whole point here is to get folks thinking about TB, because it walks among you up there in Northwest Arkansas. So let me make a couple of points before I get to the content of this slide. First of all, the incidence of TB in Arkansas and nationally is now 2.5 cases per 100,000 population. That's low. And, you know, we think of tuberculosis, well, if we think of tuberculosis, we think of it as something that comes to us from other shores, which for the nation is true. Over half of our active TB cases in Arkansas come to us from other shores or south of the border. So in the US, we're out of the habit of thinking about it. And if you haven't thought about it much recently, it's hard for me to fault you for that, because we are down to the point of being a low incidence state and country. However, I want to point out that until the COVID-19 pandemic, tuberculosis was still the #1 infectious disease killer globally, still. So, you know, we have the luxury of being low incidence here, but that's not far from true in many other places. So in Arkansas, as I said, nationally, over half of active TB cases are from other places. However, that's not true in Arkansas yet. Over half of our cases are still US born. So clinicians here have to include tuberculosis in the differential diagnosis of pneumonia and fever of unknown origin, especially in persistent and recurrent illness. We suspect that there are still many undetected cases of active and latent TB out there related to this cluster. This has been, as we've discussed, a very close-knit friend and family group. It's a large group, but what we've found so far are what I would consider to be the low-hanging fruit. I'm not going to say that that was easy. It hasn't been easy picking. Savannah Harrelson could tell you that. But we've found many of the obvious cases. What we haven't found yet is anyone outside this friend and family group. But, you know, given the long infectious period of these people, many of whom are cavitary, they've got to be out there. They've been working among other people during their infectious periods. These people are out there, and they may not match the demographic that I have just shared with you. So we need you all to help us find them and keep an antenna up for TB in East and Northeast Arkansas. It's there. Okay, so signs and symptoms of active TB. These have read like a refrain in the cases I've shared with you. So a persistent cough of more than 2 or 3 weeks duration. You know, if you've got someone who complains of recurrent quote unquote pneumonia or bronchitis, please do a chest x-ray. I can sadly tell you of a few cases whose lives could have been saved by a timely chest x-ray. It's cheap, easy, and accessible, so get it done. Think of TB if you hear of persistent fever, night sweats, unexplained weight loss, anorexia, weakness, shortness of breath, hemoptysis, and other signs and symptoms depending on the site or sites of infection, as we've discussed above. Signs and symptoms of latent TB. Okay, there are none by definition. That was kind of a trick. But these people will have a positive skin test or IGRA, the blood test, T-spot, and quantiferon. And latent TB means that they have the TB germ present in the body, but it's in a dormant condition. It's not causing active disease, and there will not be radiographic evidence of TB except maybe for a granuloma. These people are not contagious to others, and there is no reason to panic. But it is important to report them for two reasons. One, it's the law as a reportable condition to report them to us. And second of all, it's important to treat them in order to prevent for future active disease, and again, to break the chains of transmission in this nasty cluster. So diagnosing TB, active TB. So you would start again with the skin test or IGRA, and that is it's supportive but not diagnostic because it doesn't differentiate between latent and active TB. Imaging, also very important, the point I made above, also is supportive but not necessarily diagnostic. So in TB, culture, if you can get it, hard with the kids, as I've said, but if you can get it, culture is definitive. Most of the time, if you have someone with an abnormal chest x-ray, you can start with sputa ×3 morning specimens for AFB smears and cultures, and also something called an MTB-RIF assay, which I'll describe more of in a moment. Most of the time, you can start here and you'll get your diagnosis. We do see a lot of patients who get bronchoscope. Some people have trouble producing sputum. And if you have someone who has negative sputum, but a positive chest image, I'd proceed with doing a bronch. Other specimens that can be obtained are pleural fluid, tissue biopsy, which if you send it to us, we would want in saline, not formalin, please. Lymph node for TB lymphadenitis and abscess anywhere, CSF, specimens from the GU tract, bone or joint, really any suspected site of infection. And something called the expert MTB-RIF assay can be done on any of these. So we are here to help you. And what we can offer is the MTB-RIF assay. What that is a PCR for MTB, a polymerase chain reaction, looking for TB DNA. And if we find TB DNA, then we're going to do a quick look for rifampin resistance, which is the RIF assay, the RIF part of that assay. And that's just a quick and dirty look for multi-drug resistant TB. So how do you do that? You send your specimen to our lab via the closest local health unit, and our ADH courier service will bring it to us. The great advantage of the MTB-RIF assay is its fast turnaround time. We can get a result within a few days as opposed to 6 weeks waiting for cultures. Now, the MTB-RIF assay is not a substitute for culture. You would want to do both. You're welcome to send those to us because the MTB-RIF assay is not going to give you susceptibility data. And also will not give us, it's the genotyping is done from positive cultures. So, so it's also very important to go ahead and collect cultures as well. So just call the local health unit to coordinate transfer of a specimen. Again, if it's a biopsy specimen, make sure it's fresh in saline, not in formalin. And the other way that we're here to help you is just call us if you have questions. I am fond of saying that the only stupid question is the one you should have asked but didn't. So here is how to reach us. There's our phone number in bright yellow. That's the general TB program here at the central office. My cell is right below that, and you are welcome to call or text me. I have had conversations with clinicians all over the state. I'm happy to answer questions, text back and forth. A lot of folks in the state have me on speed dial now, and I am delighted to help. The URL code here with a cute dinosaur links you to a grand rounds I did on tuberculosis in Arkansas earlier this year. I also recorded a couple of months ago a lecture on tuberculosis in Arkansas that takes a much deeper dive for clinicians into radiographic findings, sort of more clinical stuff, treatment stuff, research, and that will hopefully get uploaded to the Learn on Demand platform soon. And there you can actually get a CME credit for watching it. It's a great platform. Should appear anytime now, I think. So that is what I have to share today. And I'm gonna open the platform for questions.
So anyone have any questions for Dr. Chai? Dr. Chai, I did see Dr. Dahl is present with us. I didn't know if you had anything specific, but
oh, okay, that's great. I'm glad to hear it. So Dr. Dahl, sorry, I'm still a Zoom idiot, y'all. I'm so sorry. I'm trying to get to back where I can actually see people. Not sure how to do that.
If you click on the share screen on the bottom, Dr. Chai, hit it again, and it will it should give you the option to stop sharing.
Okay. Then
actually, I think I can take that over for you.
Okay. So anyone who wants to capture the URL, do it now. And yeah, if Dr. Dahl has anything he would like to add, I'd sure be happy to have him do so.
There you go. I was able to stop your share for you.
All right.
I just want to say, first off, thanks, Dr. Chai. That was an excellent presentation, and obviously really good to have an overview of the ongoing outbreak. Unfortunately, you know, these conditions, you saw how dramatic they were in kids. The big thing that I think is important for everybody to recognize is that tuberculosis does not always progress rapidly. It oftentimes can take months and even years for people to go from an initial infected state to where they're showing symptomatic disease. So when you find an active case, there's a large catchment area of people that we'll have to look at in order to determine, is there anybody else who might also be infected that's not symptomatic? If you have children who are infected or who are contacts to an individual who are infected, especially if they're less than 4 years of age, and really especially, less than 5 years of age, and really especially if they're less than 1 year of age, your risk of having that disease progress in a more significant way and more rapidly goes up the younger they are. So infants are at much greater risk than toddlers, who are at greater risk than young children, who are at greater risk than adolescents. So it is something that when we identify cases like this, it's important that we find out, hey, do you have any children that you're around that spend significant time with you? And make sure that those kids are also referred to the health department for evaluation so that we can prevent as much progression of disease. I mean, you can see how significant that little 2-year-old, his condition is going to be. After his course of treatment, he's going to require surgery to have a spinal rod placed, and he's going to have fusion of several of his vertebrae in order to provide a stable back for himself so that he can continue to grow. So this is going to impact him for the rest of his life. And it can be something that it might be difficult for families to really wrap their head around, the impact of this, because they think, cough, my kid's had 100 coughs, why is this cough any different? But these are things that, you know, when you suspect, or if you have suspicion for it, it's really important that we pursue until we have an answer one way or another.
Thank you. I think those are really excellent points. And your point is well taken, that TB does percolate for a long time. You know, by the time someone develops symptoms, they have been infectious for potentially several months. And especially in some of these cavitary cases, my goodness, you know, a cavity has millions of TB germs in it. So I'm telling you, folks, there are TB cases walking among you up there. Keep your antenna up. They may be young, they may be old, they may be children. But they're out there, and we need to find them and get them treated. Other questions?
Dr. Chai, I don't have questions. I just want to commend you for getting clinicians to this meeting. I want to reflect for the young people out there, we rely on you. Arkansas is proud of our work in TB. We just lost Dr. Bates, graduated 1957, and was working on TB with us until this year. So my hope, our hope is you young people out there, think TB. I'm an epidemiologist. My thinking is different. We think of causes, cause and effect. You folks think about making a diagnosis. It shouldn't be so different. Dr. Chai is talking about have your 3 differentials out there. Our frustration at the TB program is that you are our representatives out there. The challenge is think TB. That's our challenge. Delayed diagnosis is linked to think TB. So my hope is that this is going to make a big difference out there. We think TB every day, and it's maybe easier on us, but we really want you to buy into this idea of think TB, especially at this time. Thank you so much, Dr. Chai.
Well, thank you, Dr. Mikasa. And, you know, tuberculosis, just like COVID-19, is airborne. So, you know, there's a lot of stigma attached to it, but we all got to breathe, right? There's not a reason for people to be ashamed, but there sure is a reason for people to be treated. So just, you know, again, persistent cough, fever, all those symptoms we talked about, do an IGRA. We prefer those over the skin test these days. Do a chest x-ray. Chest x-ray looks funny at all. Collect 3 sputa. You know, these are not complicated or difficult to access. And we would really like to, like I said, bring the romp of this germ to an end in Arkansas.
Dr. Chai, if I could just add on one kind of new development. So historically in pediatric cases, a tuberculous skin test, or what we used to call a PPD, was kind of the benchmark of what was being recommended for kids if they were initially less than 4 years of age when the IGRA came out. Then they showed, hey, IGRAs actually work. And by IGRA, we mean like a T-spot or a quantiferon gold. But they said, hey, actually, it's still effective down to 2 years of age. And with the more recent data, just in IDSA or the ID week last week, there was presentations on the subject where AAP is actually going to start recommending IGRAs all the way down to 6 months of age. So it's really going to be nice because you don't have to get them back for a second visit to read a TST. You just run an IGRA on them and work with that. So
yeah, thank you. That's a great point.